Welcome to this tutorial. So basically this is a comprehensive review of topics under adult medical surgical nursing. In this session we are going to focus on 4 major topics, and these topics, the first one, they are going to be discussed in this order. We are going to start with appendicitis, followed by sickle cell anemia, then followed by leukemia, then followed by hemophilia. Okay, so these are the topics that we are going to cover in this session. And for each and every topic that we are going to cover in this video, we are going to have some specific focus on how basically questions can be asked in terms of MCQs, essay, as well as cross-match, including one-word answer. Okay, so this is going to be our topical objective. For each and every topic that we are going to cover, we are going to look at the definition of that particular condition. We are going to review some anatomy and physiology where necessary. Then we're also going to look at the etiology, the cause of that condition. Then we're going to look at risk factors. There are some conditions which are just associated with some risk factors. For example, we have some kind of cancers. All cancers are idiopathic and they are associated with a risk factor. Because when we say the cause, we mean to say that particular thing that leads to something. So there are risk factors. And then we're also going to look at the pathophysiology, the most important one. The pathophysiology determines the signs and symptoms of a particular disease. Okay, so basically after looking at the pathophysiology, then if possible, for any condition, we're going to look at its classification and types. Then we go to clinical manifestations, the signs and symptoms. How does this particular disease present? And then we're also going to talk about some diagnostic investigations in some conditions. And then we're also going to look at the medical as well as surgical management of that particular condition. Okay, so basically I am going to assume that you know the general management, the general nursing management of a patient. Then if you know the general nursing management of the patient, you just manipulate the general management of the patient into a specific management. Okay, for example, if you are managing a patient with an infectious condition, cannot be the same with when you are managing the patient with a non-infectious condition. That's what I mean. So these are going to be our topic objectives, and this is how you are going to study and prepare for this particular test. So now let's start with appendicitis. So now the question I should ask you is, or you should ask yourself is, what is appendicitis? It is a condition. Yeah, it is a condition. So now the question you should ask yourself is, what is appendicitis? I've given you the topic objective, and you should be able to follow them through as we are discussing the appendicitis. Okay, this is a comprehensive review. Make sure that you follow through. I'll be a bit faster just to make sure that we manage our time well. So what is appendicitis? Appendix, in this statement, or rather in this condition, or this word, there is the appendix and the itis. Itis means inflammation. Appendix is an immune organ. Okay, it's part of the GIT. Most of the functions of the appendix are not very much well known, but some literature have suggested that appendix plays a critical role in immunity. Okay, because it stores some important bacteria we call normal flora. Okay, so now let's review at what is appendicitis and then what follows in. As you can look at this image here, this is the GIT, the gastrointestinal. We're looking at the large intestine. Then at the end of this large intestine, that's where we have this small organ here we are calling the appendix. So when this appendix gets to be inflamed for a number of reasons, then that's what we call appendicitis. So appendicitis is a medical condition, is a surgical condition that involves the inflammation of the appendix. So now let's review the appendix. So we have the large intestine, then we have the small intestine, then we have a normal appendix which looks like this. Then we have the rectum and the anus here. So now this is the appendix, which major role in the body is not well known, but some literature, as I mentioned, say that it plays a critical role in immunity. How does that do that? In case of some kind of diarrhea or any, in case of someone gets the broad spectrum antibiotics, what happens is that those broad spectrum antibiotics are going to destroy even the important bacteria. So this appendix here is the one is responsible for storing those normal flora. Okay, the normal flora, those are and safe bacteria that help to even enhance the immunity by making sure that each and every invading parasite gets to be killed before it can even reach far. So when it gets to be inflamed, it looks like this. You can see here, this is the normal appendix, but when it is inflamed, it looks kind of like this. You can see here. Okay, so now we are yet to fully define what it is. Look at what causes it, and then we see in the cause we are going to associate it to the pathophysiology. Then we look at the signs and symptoms, and then we manage this particular condition. Okay, so now, as I earlier mentioned, appendicitis is the inflammation of the vermiform appendix, usually caused by obstruction of the appendiceal lumen. If not treated, it can lead to complications like ruptured appendix and peritonitis. So this is the complete definition of an appendicitis. If the question required you to give to get 5 marks on this particular question, and then just definition, you define it like this, you are going to earn the entire 5 marks. I think this is one thing that I've been mentioning over and over. So by just doing this, you earn your 5 marks if the question was to ask you define appendicitis. So now, what causes really, what causes appendicitis? What is the etiology? Etiology, we're just basically looking at the origin of a disease. What causes this particular disease? So now, you should be able to know that the main focus on what causes appendicitis, we have one major thing. That's where everything arrives, and that is the obstruction. So get me right. Obstruction is it is the major cause of appendicitis. Okay, I've mentioned to say obstruction. So now let's try to break down this obstruction. How does obstruction comes about? How does obstruction comes about? Don't worry, we are going to review it very well. So we have fecal leak. When the feces, because that is part of the large intestine. So if the feces get too hard, they form more like a stone, and then they cross the lumen of the appendix. Okay? Lymphoids, hyperplasia, foreign bodies, tumors, parasites. So now, let me explain this in detail. So what do I mean when I say the appendix? We know that the appendix is this one. Okay, appendix. And I said the major cause of appendicitis is the obstruction. Okay, take note of that. Obstruction. What causes this obstruction? In case of some kind of fecal leak. So we are going to use fecal leak to answer even other questions. So now, where is this obstruction going to occur? The obstruction. So now, this is basically the large intestine, and then at we can see we can see the appendix here. Okay, so now I said the major problem with appendicitis is obstruction. This obstruction is going to be caused by a lot of things. One of those things is Sickle. When the feces, just the feces, because the large intestine, that's where there is what happens, absorption of water. So it's more like we want to concentrate the feces. So those same feces, they are capable of obstructing the lumen of. So let me just get. So this is the lumen of the appendix. Okay. So once this lumen of the appendix is obstructed, that's what we mean to say the major cause is obstruction. Okay, so this is the lumen of the appendix, and then if it get to be obstructed in case of Sickle or any foreign substance, okay, or it could be parasites. Okay, so now due to these things I've mentioned here, they can clog the lumen of the appendix. Okay, once they clog the lumen of the appendix, we are going to see what is going to happen step by step in the pathophysiology. But what happens is that once this lumen get to be closed, what happens is that there is going to be an inflammatory, there is going to be inflammation. Why? Because this appendix has some what we call epithelial cells. These epithelial cells secrete some substances. Now, the secretion of these substances are going to continue like that. They are not going to drain. So because of that substance is going to be continuously being secreted and not having the outlet, they are going to cause pressure. Okay, there's going to be too much pressure in the appendix, and then due to that, this appendix is going to be inflamed. Okay, and in some cases it can actually burst. So now, since you understand this concept, let's go back. Let's go to the pathophysiology so that you can relate to this concept. I just hope that you understand what is going on here. So now, for any reason, lymphoid, hyperplasia, foreign bodies, tumors, parasite, Sickle, they can cause obstruction of the lumen of the appendix. So now let's look at the pathophysiology of the appendicitis. What really goes on? Like I mentioned, to say obstruction is the major issue. One of the examples I gave is the Sickle. They are also parasite, foreign substances. Okay, so now what happens is that when that lumen, let me draw something. The lumen that I drew there, okay, this is the appendix, and this is the lumen. When this lumen gets to be blocked, so when this lumen gets to be blocked, what is going to happen is that this one is an epithelial cell, okay, like it continues secreting substances, mucus substance. So this secretion is going to continue feeding in inside the appendix continuously. So what is this going to lead to? It's going to lead to increased pressure in the appendix. Okay? And due to this obstruction that has occurred here, okay, due to that increased pressure and obstruction, due to this increased pressure, there is going to be reduced blood flow. Okay, reduced blood flow is going to occur due to obstruction. So now, when blood flow has been reduced, it's a process of stasis. Okay, whenever there is stasis, there is bacterial growth. Bacteria find it peaceful in developing in those particular areas. So wherever there is reduced blood flow, there is going to be bacterial growth. Whenever there is bacterial growth, like whenever bacteria invade that particular area, what happens is that we need the process of inflammation, because this is the process by which neutrophils comes on at the site of infection, so that this particular infection can be removed out of the body. So that's why the infection is going to appear, the inflammation is going to appear there. Okay, and then if inflammation occurs, this thing can actually lead to necrosis, and after necrosis, then due to all the combination of these factors, the appendix can actually rupture, okay, pouring its content in the abdomen, and that can lead to peritonitis. Now, one thing about the ruptured appendix is that a ruptured appendix is a medical emergency. That's one thing you should know. A ruptured appendix is a medical emergency. It requires quick intervention because it leads to peritonitis, and this can actually lead to more severe other things that can be caused. So this is basically the pathophysiology behind the appendicitis. I hope it was loud and clear. Now, looking at these looking at the pathophysiology of appendicitis. So now let's try to associate the pathophysiology with the signs and symptoms. Okay. So now, one of the signs and symptoms of appendicitis is that we have what we call peri-umbilical pain shifting to the right lower quadrant. Okay. So usually this pain exists because of the connection, okay, that exists. It's about the connection. You know, this pain is able to be felt in other areas because of areas of innervation, because it is still in the GIT. So usually there is peri-umbilical pain that usually shifts to the right lower quadrant. Okay. Why right lower quadrant? It is because this pain is actually coming from the appendix, because the appendix is in the right lower quadrant. So there is peri-umbilical pain just because of the connection between the appendix and the in the large intestine. That's why usually there is peri-umbilical pain that shifts to the lower right quadrant. Then there is what we call positive McBurney's point. So this one we are going to understand. We are going to understand it in the classical signs of appendicitis. For now, just hold on it. Then we usually have nausea and vomiting. Okay, nausea and vomiting occurs sometimes due to irritation or irritation that occurs in the GIT, and this irritation is going to it also have some effects. It rather stimulate what we call the vomiting centers. So once the vomiting centers get to be stimulated, then someone feels this. Then there's usually fever due to inflammation, the loss of appetite due to the same pain that is being felt when someone wants to eat but they're still feeling pain. Then there is rebound tenderness. This rebound tenderness is coming because the appendix is it's actually more like an internal part of an organ. So once you hold and then you release, someone is going to feel pain in the right lower quadrant. Then there is guarding. Guarding is someone being protective so that you don't touch that particular area. So when you are trying to touch that area, you see the muscles of the stomach trying to come together, more like guarding that particular side so that you don't reach it. Okay. So now we have what we call okay, we are going to classical signs of appendicitis, but now let's look at the diagnostic investigations. Under diagnostic investigations of appendicitis, we have what we call full blood count. Usually there is an elevation of white blood cell count. Why? Because there is an infection that is going on. Then on ultrasound, you are going to see an inflamed appendix. Even CT scan, you are going to see an inflamed appendix, and so on, just like urinalysis, physical examination, as well as history taking. Okay, so maybe to talk a bit about history taking, you are going to, or someone is going to complain of pain in the right lower quadrant. Then physical examination, there is usually going to be rebound tenderness on palpation. Yes. And you are going to observe the patient guarding, just like there's going to be guarding just like that. Then now, on the classical signs of appendicitis, we have what we call McBurney's signs and Lofson's sign. So or when do these signs become positive? So when we say positive McBain sign, we mean to say you are going to there's going to be tenderness in the right lower abdomen. Okay, in the right lower abdomen you are going to feel some pain. Okay, just about 1/3 from the umbilicus. Okay, when you are going to the right iliac fossa, then you are going to someone is going to have some pain in that particular area, or rather tenderness. Then how about Lofsin sign? Lofsin sign, there's going to be pain in the right lower abdomen when the left lower abdomen is pressed. You press the left lower abdomen and then pain exists in the right lower abdomen. Okay, more like pain shifting. That's what we call Lofsin sign. That occurs just because of the connection that exists. Okay, so when you look at some medical and surgical management, usually we have one surgical management here. In case of appendicitis, someone is going to undergo appendectomy. Appendectomy is a surgical removal of the appendix. This one is a surgical management. Okay, then you can also give some IV fluids, antibiotics, and analgesics for pain relief. Okay, and these are the complications of appendicitis. If it is not treated promptly, it can lead to peritonitis, abscess formation, we are talking about necrosis, sepsis, intestinal obstruction, even shock can be caused. So these are the complications of appendicitis. Just like I mentioned, I just want to give you a comprehensive review. Specifically, I'll be focusing more on the pathophysiology, and then on the signs and symptoms. Then on other management, you can actually read through just like that. That's how we're going to help each other in this session. Okay, so now we are done with appendicitis. I hope you got one or two things from there. Okay, mainly whenever you are writing the test that is going to require you use all method, MCQs, cross match, one word answer, and essay, you need to understand the pathophysiology of diseases very well, because from the pathophysiology of a disease you tell the signs and symptoms, and then from the pathophysiology of a disease you can also tell the investigations that should be done. So now let's look at the sickle cell disease. Okay, so what is a sickle cell disease? This is going to be called sickle cell disease because there are a lot of there are a number of classification of sickle cell disease. So what is a sickle cell disease? Okay, so a sickle cell disease, of course, it is a hematological disorder, something to do with blood. Okay, so the sickle cell disease is a group of inherited blood disorders that cause red blood cells to become hard, stick, and C-shaped. As you can see here, we have the normal size of blood there, round and biconcave, but when you look at these sickle cells, they are no longer the size of a red blood cell that can be able to do what a normal red blood cell does. It transports nutrients, it transports, the blood transports oxygen. The blood also plays a critical role in excretion. So now, if these particular red blood cells have become sickle shaped, even the oxygen carrying capacity gets to be reduced. Okay, so now I want you to understand step by step on how sickle cell disease comes about. So now I have mentioned to say we have a normal red blood cell, and then it is going to become sickle shaped. So this sickle shaped is due to some genetic mutation. Sickle shaped is going to be caused due to some genetic mutation. So now I just mentioned to say sickle cell disease is under a lot of classification. Okay, so this classification mostly are going to be asked in exams, because these classifications are very much important for you to know, and they're very much important in the genetic cross-up, because this is where, or rather how the disease gets to be built up. So now the first one we're going to look at is sickle cell trait. Under sickle cell trait, we have a heterozygous form. We have one, we are talking about hemoglobin, okay? We have a normal hemoglobin. When a hemoglobin is normal, it's going to be A, and we have one hemoglobin that is sickle. So that's what we mean sickle cell trait. And sickle cell trait, its genotype is HB, hemoglobin, A, normal, S, sickle shaped. I hope you understand that. It is a heterozygous form. Okay? And the sickle cell trait is usually a symptomatic carrier state. And most of the time, people with who are asymptomatic carrier state are women. Okay? So sickle cell trait is asymptomatic. If someone is having sickle cell trait, they are going to present with little or no symptom of this particular sickle cell disease. How about the second one, which is sickle cell hemoglobin C disease? How about it? Let's focus mostly on the genotype. We've looked at the sickle cell trait. We have hemoglobin. In the sickle cell trait, we have hemoglobin that is normal and the hemoglobin that is not normal. Then we have the sickle cell hemoglobin C disease. What are the genotypes in this? We have one that is sickle shaped, and the other one which is a hemoglobin C. So like we have milder than sickle cell, because HBSS, this one is a sickle cell patient. So it's rare that this particular person is going to inherit this particular disease, okay? But it can still cause some complications, okay? This particular person can, yes, they are at risk, but not as compared to other classification of this particular disease. Then we have what we call sickle cell beta thalassemia. The sickle cell beta thalassemia genotype is HBSB thalassemia. So in this sickle cell, we have the combination of the sickle cell and the beta thalassemia gene, okay? Thalassemia gene. And this particular thing can either be HBSBO, which is severe, or no normal HBA produced. Then we can also have HBSB plus, which is milder, and some normal HBA can be produced in this particular classification of sickle cell. Then we have the most common and severe form of sickle cell disease. We have sickle cell anemia. And sickle cell anemia, we are talking about both genotypes not being okay. We have hemoglobin, which is sickle shaped of the mother, and hemoglobin, which is sickle shaped of the father. They combine together, they are going to form this particular disease. So it is a homozygous form and inherits HBS from both parents. Okay, so this is the most severe type of sickle cell disease. For this reason, let's now focus more on sickle cell disease. We are going to focus more on the sickle cell disease, anemia specifically. Okay, so now we want to understand how sickle cell anemia is like, what are the chances, what are the genetic predisposition of someone having sickle cell anemia. So now here comes in, we want to talk about the severe form, which is the sickle cell anemia. Under normal circumstances, we've described to say that a normal red blood cell looks like this, but a blood cell that is sickle shaped looks like this. So what is the effect of this? The oxygen carrying capacity gets to be reduced, because the surface area has also been reduced. Okay, so one thing about this sickle cell is that these sickle red blood cells is that they are stiff, and the sickle cells get stuck. Okay, so because they are stick, they are going to stick to each other, and we are going to look at the result of them sticking to each other, what they are more likely to cause. So now, let's look at what is the definition of the sickle cell anemia, because now I've specialized. The sickle cell anemia is a genetic or autosomal recessive hemoglobin disorder characterized by production of abnormal hemoglobin. The abnormal hemoglobin is HbS, which causes red blood cells to become rigid, sickle-shaped, and leading to chronic hemolytic anemia and vaso-occlusion. Hemolytic anemia, we just mean to say the anemia that is going to be caused due to destruction of red blood cells. And then vaso-occlusion is because this particular red blood cell has become sickle-shaped, we've described to say that they are sticky and they are stiff, so they are going to occlude some small blood vessels. Okay. So now, if we have parent 1, we want to explain this genetically. If we have parent 1 and we have parent 2, then if parent 1 is having some kind of sickle cell trait, we mean to say in their genotype, they are not really sick, they are having A, which is normal, and they are having S, which is sickle cell. And then we have parent 2, probably the father, because usually parent 1 is a carrier, the mother. We have the father now who is normal. They have no trait of sickle cell. Okay? They are normal. They have AA. This one is AS. So what happens is we want to find out if these two were to meet. Okay, were to be met and then produce children. What are the chances that their children are going to be sick? So here now is the probability. The first child is going to have sickle cell trait, meaning they are not going to have the disease, but they are going to have a trait. If they meet someone, if this person get married to another person who is having a sickle cell trait, then the chances of them getting a child who is having sickle cell anemia are 50%. You understand? Then the second child is also going to have a sickle cell trait, which is genotype A and S. Then we are going to have 2 normal children who will not have any trait of this particular disease. This is what it means. So the chances of getting a trait and normal children, trait children and normal children is that it's 50-50, provided the parent 1 is a carrier and then parent 2 is a normal one. So if this is the mother, this is the father, these are the chances of the children getting sickle cell trait, not getting the disease. So now what does this mean? This means to say if the mother is a carrier and the father do not have a disease, meaning their children, none of them is going to be affected. But in case when these children, same children, because we've said the 50 chances of getting a trait, none of them is going to be affected by the sickle cell disease, sickle cell anemia, but some of them are going to become carriers. Now the thing is here, now when this particular person who is a carrier falls in love with another person from another family who is a carrier, then the chances of them getting a child or children, or maybe 2 or 3 children who are actually what we mean is the chances are 50-50 of having a child who is sickle cell anemia, because they are both carriers now. When we cross match them, we are going to find that the chances are 50-50. So if this particular couple is going to have 20 children, the possibility that out of those 20 children, 10 are going to be affected by sickle cell, not trait, but with sickle cell anemia. I hope you understand that. Let me try to explain it more here. So if we have AA, then AS. Okay, this one is normal, this one is a trait. We cross, okay, A to A, A to S. Then we cross A to A to S. So you see, this one is going to be normal, this one is going to be normal, but these two are going to have a trait. If they meet another person from another family who is a trait, then they are in trouble. This is what we mean by this disease. Now, since we are talking about the hemoglobin it has a problem with hemoglobin. So now, what really happens in a hemoglobin for it to become sickle shaped? So now understand the concept here. What really happens to the hemoglobin for it to become a sickle cell? Because it's about alterations in the normal chains of the hemoglobin. So what happens is the gene mutation. Actually, we have an amino acid glutamate being replaced by valine. Okay? In place of glutamate, because this one is HB, which is normal, it should have glutamate. But in case of sickle cell anemia, this glutamate is going to be replaced by an amino acid called valine. Then this valine is going now to lead to a hemoglobin that is sickle. So this is basically what happens, and this question is going to be there MCQs, okay, about sickle cell disease, sickle cell anemia. Glutamate is replaced by valine, as you can see here. This is amino acid, and this is the only difference. This is the only thing that causes sickle shaped red blood cells. Everything you can check, we have valine here, we have histamine, we have leukosin, we have threonine, we have proline, we have glutamate, but here they have just replaced. If we have glutamate here, then even this HBS is going to be HBA. This is where the misconception comes in. So now you can just look at glutamate and valine as a simple issue, but their structures are very different. You can look at these two structures here. Their structures are very too different. Due to this structural difference, this is the reason why the red blood cells become sickle shaped. Okay, so now there are what we call sickle cell crisis. Questions are going to be asked on sickle cell crisis. What kind of sickle cell crisis do we have? The red blood cells have become sickle shaped. Now what is the fate? What is going to happen? Because they need to circulate. So under sickle cell crisis, there are major problems that these sickle shaped red blood cells are going to cause in the body. And these sickle cell crises are very much important to be known by the health practitioner. The first sickle cell crisis, we have about 4. The first sickle cell crisis is the vaso-occlusive crisis. What happens? Because these sickle-shaped red blood cells have now they have become sticky and they are stiff and rigid. Then what happens? Because the normal red blood cells, they are flexible so that they can twist through, and their volume ratio is very good, so that they can easily pass through or cross the capillaries, through the walls of the capillaries and blood vessels. Now they have become sticky and rigid. What is going to happen? They are going to occlude the blood vessels. Okay, this is what we mean. So the vaso-occlusive, we call it pain crisis. Why? There's going to be severe bone and joint pain. Okay, what happens? Just imagine in a situation where the particular tissues are not receiving enough blood. Just like the way when you sit on your leg for an hour, how you feel, okay? That kind of numbness. And then that numbness happens in the blood vessel. So there's going to be pain crisis. There's going to be severe bone and joint pain, usually common in the back, chest, and limbs. Okay, this is vaso-occlusive crisis. Occlusion of the blood vessels, capillaries. Then we have hemolytic crisis. What happens in hemolytic crisis? There is sudden increase in red blood cell destruction. Okay, sudden increase in red blood cell destruction. Why is this going to come like this? The thing is, a normal lifespan for a red blood cell is about 120 days. But imagine in a situation of a sickle cell anemia, the lifespan of a red blood cells, because it has become sickle shaped, it needs to be removed within 10 days. So meaning, these particular red blood cells need to be removed out of the body after 10 days. Then that is what we're telling hemolytic crisis. There's going to be sudden increase in red blood cell destruction because the lifespan has reduced. So the person is more likely to experience severe anemia and jaundice. Why jaundice? Because the destruction of the red blood cells lead to the accumulation of bilirubin. This bilirubin need to be conjugated by the liver, okay? But it's not always that the glucuronic acid is there. So what happens is that it's going to penetrate in areas, tissue, the eyes, the sclera, conjunctiva, everywhere. You are going to see yellow discoloration of the skin. Then what is the other crisis? We have a plastic crisis. What about a plastic crisis? There is bone marrow temporarily stop producing red blood cells. Okay? So, because the red blood cells have stopped being produced, what is going to happen is that there is going to be severe anemia and low reticulocyte count. Severe anemia and low reticulocyte count. If the reticulocyte count get to be reduced, then a lot of problems are going to arise from there. And then, last but not the least, we have the sequestration crisis. What happens is that blood get to be trapped in the spleen and the liver. Then there's going to be hypovolemia, even shock. Shock, though, is more common in children, but it can also happen in adults with the spleen remnants. So basically, sequestration crisis is going to happen because blood is going to be trapped in the liver and the spleen, because it is not flexible enough. There are no longer the red blood cells that can twist and do this, you understand. So basically that's what usually happens. So now, how are you going to associate with what we have discussed? Because the pathophysiology we are talking about is just reducing the oxygen carrying capacity due to the sickle red blood cells. So now, what happens? How is it going to produce? How is the patient more likely to present? We've looked at the pathophysiology. So now I want to understand the clinical presentation. How is the person more likely to present? So there's going to be chronic anemia. Why chronic anemia? Chronic anemia is going to come in this. It's going to follow the crisis that we've just from looking. It is going to be due to hemolytic crisis. So why chronic anemia? Because there is continuous destruction of red blood cells due to the reduction in the lifespan of the red blood cells from 120 days to 10 days, because they are now sickle shaped. So this particular person is going to have chronic anemia because the destruction of red blood cells is too sudden. Okay? Then the particular person is going to feel fatigue and weakness. Why fatigue and weakness? Because the red blood cells plays a critical role in the transportation of oxygen that is important in the oxidative phosphorylation for the production of energy. Now, in case of sickle cell anemia, the red blood cells have become sickled and they are not producing enough oxygen needed to produce enough energy. Hence, they feel fatigue and weakness. Then they are more likely to have jaundice. Why? Because this is happening to hemolytic crisis. There is going to be hemolysis, breakdown of red blood cells because the lifespan has reduced. Then there is going to be pallor. Why pallor? Because the hemoglobin, the normal hemoglobin that add color, the color red to blood, has been malfunctioned. It has been altered. Then there is going to be delayed wound healing. Why delayed wound healing? Because basically the red blood cells are very much important for the transportation of oxygen and everything. You know, it's not only apart from that, whenever there is anemia, whenever blood get to have an infection, even the other cells of blood get to be affected. Okay? Because the delivery of platelets to that particular area or the site of infection is going to be reduced. Then there is usually going to be leg ulcers, this is due to the occlusion of blood vessels. Occlusion of blood vessels, is going to cause hypoxia, and hypoxia is what leads to cell death. So there's going to be ulcers in the lower legs as well as gallstones. Why? Because there's pigmented stones. Why gallstones? The reason of gallstone is this: because the red blood cells are being destroyed at a faster rate than normal, so bilirubin concentration in the body increases. Once it increases, it becomes too concentrated, and when bilirubin gets to be very much concentrated, stones can be formed, and that's what we call gallstones. Okay, so these are the clinical presentation of this particular condition, which is sickle cell anemia. Then under medical management, we have oxygen therapy, IV fluid just to hydrate the patient. Then you can use some strong analgesics because of the pain that is going to happen due to vessel occlusion, which is one of the crises. Then we can also use antibiotics if infection is get to be what suspected, because we have impaired the body's ability to defend itself. Then blood transfusion in case of severe anemia, okay, because the red blood cells have become sickle shaped. So if you replace that blood with the blood that is coming from another person, it's more like you are reducing the number of fake copies of red blood cells so that the normal blood cells can come in and help this person carry out the function. Okay. Some diagnostic investigations usually involve full blood count, peripheral blood smear, hemoglobin, erythrophoresis. This one is a confirmatory test that measures the presence of an infected hemoglobin, which is S. Then we have sickle cell solubility test for screening. Then serum bilirubin is going to be raised. Why? Because there is too much destruction of red blood cells. Then on X-ray and MRI, you are going to see some bony complication, denoting to say maybe the bone marrow is malfunctioning. Complications of sickle cell anemia, we have stroke, acute chest syndrome, pulmonary hypertension, renal failure, avascular necrosis, chronic organ damage, as well as the infection. Okay, so now on the complications, I wish I had enough time to explain each and every one of these. But what is going to happen? Let me start with the first one, stroke. I'm just going to explain the first one. The rest you are going to help yourself. So with the stroke, why stroke? Stroke is going to occur because there is basically the blood vessels have been occluded. Even those blood vessels that send blood to the brain have been occluded. So if the brain cannot receive enough blood, it means the brain can also not receive enough oxygen. If it cannot receive enough oxygen, then it temporarily stop working, and that's what we call stroke. Okay? The rest you are going to find exactly. In case you have issues, please feel free to comment in the comment section, and then I'll be able to provide an explanation from there, or you can inbox me on the line that is going to be provided in the comment section. So now we are done with an overview of what sickle cell disease is all about, and I hope I had to break down some important concept there. Okay, very much pathophysiology, very much comprehensive explanation on the pathophysiology. Pathophysiology is the disease process, very much important. So now let's also talk about something known as leukemia. So what is leukemia? Basically, leukemia is a cancerous disorder. It's a cancerous disorder of the white blood cells. But now one thing about leukemia is that leukemia does not only, yes, it directly affects the white blood cells, but it indirectly affects other formed elements. By formed elements, I mean platelets as well as the red blood cells, apart from these white blood cells. So now let's try to look into what leukemia is. So leukemia is a group of malignant disorders affecting blood and blood-forming tissues of the bone marrow, lymph system, and spleen. So now, this is one thing about leukemia. Under physiology, you have learned somewhere to say the process of hemopoiesis. We describe to say that hemopoiesis is the process of blood formation of all lineage. We mean to say the white blood cells, the red blood cells, as well as platelets, they have one major source of where they get to be produced. That's what we mean. Now, they have one major source of where they get to be produced. Okay? In case of this, leukemia involves disorder of the white blood cells due to malignancy. Okay, so it affects the bone marrow. We are going to look at how exactly something that affects the bone marrow, lymph system, and spleen get to present with. So we can also say that leukemia is a cancer of blood-forming cells in the bone marrow. So now, it is the cancer of blood-forming elements. Mostly, it affects the white blood cells, but it also affects other formed elements of blood. So now, let's look at this process. We are going to say multipotential hematopoietic stem cell. This is where all blood cells originate. Let's look at two major ones. We have common myeloid progenitor and we have common lymphoid progenitor. How about the myeloid progenitor? This is the precursor for the formation of megakaryocytes, which we are going to call the platelets. Then they are going to form erythrocyte, red blood cells, then just like that. These are what are going to be formed from the myoprogenitor. This is very much important. Pay particular attention. On the classification of leukemia, here is also one of the catch on the classification of leukemia. We have common myeloid progenitor and we have common lymphoid progenitor. On the common myeloid progenitor, this is where there's production of megakaryocyte. Megakaryocyte, we're talking about the platelets, and then we have erythrocyte. Okay? So when we look at these cells, we have basophil, neutrophil, eosinophil, monocyte, as well as red blood cells and platelets. They are produced from the myeloid progenitor. Now, what gets produced from the lymphoid progenitor? We have the lymphocytes. Okay, basically the lymphocytes. We have two types of lymphocyte: T lymphocyte and B lymphocyte. T lymphocyte, that's where we have CD4 cells and then we have CD8 cells, and then B lymphocytes, that's where we have the plasma cell. So now, the problem with leukemia is that it affects this particular area, the hematopoietic stem cell. That is what gets to be affected. Let's read again. Leukemia is a cancer of blood-forming cells in the bone marrow. Specifically, we have two types of bone marrow. We have the red bone marrow and white bone marrow. Yellow. So the yellow bone marrow usually contains fats. However, with the red bone marrow, that's where production of red blood cells and other cells get to occur. So now let's look at the disease process. You can look at this. This is a blood vessel, and this blood vessel is having the normal red blood cells. There are platelets within it, and then there are white blood cells. Okay, so now when you look at this, is the normal blood. This is how it should be. But in case of leukemia cells, you are going to find that in case of leukemia, the red blood cells are just in a normal shape and platelets are just in a normal shape. But the problem with that, the white blood cells get to become cancerous. They multiply uncontrollably, as you can see here. So now, how do they affect the red blood cells? They are going to affect the red blood cells because most of the space is going to be occupied by the white blood cells. So this is what happens in leukemia. So there are also going to be anemia in leukemia. Why? Because the red blood cells have been suppressed of their space. We are also going to have issues with platelets because the space has been suppressed. As you can see here, there are platelets which have been suppressed there and they cannot do their function really well. So this is the disease process of leukemia. These cancerous cells is just abnormal growth of these particular cells. That's what we basically mean. So what is the exact cause of a cancer? Cancer has no cause. That's why we mean to say it's idiopathic. It's idiopathic because it has no cause, but it is associated with some risk factors. So what causes leukemia? What causes suddenly the bone marrow to start developing some kind of malignancy, which is a cancer? This happens due to genetic and environmental factors. Then the other one, we have chromosomal abnormalities in case of Down syndrome. Okay, when we mean Down syndrome, we mean to say some chromosomes get to be misplaced. So in Down syndrome, that's where you see some physical thing. Some physical example I can give you is whereby you see the maybe you see the child with 4 fingers, just like that. That is a genetic issue. So in Down syndrome, it means that the particular genes that were meant for the bone marrow production were not there or were impaired. And then in case of chemical agent and chemotherapeutic drugs, because these drugs, they are associated with carcinogen, let's say smoking, radiation, these ones, the end product is that they produce carcinogen, which is the main cause of cancer. Then in case of viral infection, radiation exposure and previous chemotherapy, this one can cause leukemia. So these are just risk factors. These are not causes. There is no cause for leukemia. It's just associated with some risk factors. So now let's look at the classifications of leukemia. We have 2 major classifications of leukemia. And please, I want your life to be very, very easier here. The first classification of leukemia is based on onset and severity. Onset, how it starts. Yeah. And that's the first classification of leukemia. Then the second classification of leukemia is based on what kind of white blood cell has been affected. Remember what I was telling you here? We have myeloid progenitor and we have lymphoid progenitor. So we're just looking at what of these two has been affected. So now let's try to first understand classification of leukemia based on onset and severity. Based on onset or severity, we have acute leukemia, meaning its onset is rapid and the progression, there is proliferation of immature hematopoietic cells. Okay, blast, we mean to say something is immature. Okay, that's where they are more like precursor cells, the mesenchymal cells where things are going to be produced. So there is going to be rapid onset in acute leukemia, and the bone marrow fails to produce normal blood cells because it is producing too much of immature cells and requires immediate treatment because it is an acute. So now I want you to note one thing about acute leukemia. Why is there acute leukemia? Look at this. We are looking at the proliferation of immature cells. There are immature cells which are not capable. They have not reached their term. They are not mature yet, and then the production proliferates. So what happens is that there is rapid. The production is faster. So the normal cells are being replaced by fake copies, just like that. Okay? Because the fake copies are a lot, that's why we are going to have an acute leukemia, and it needs immediate treatment. This is based on onset and severity. Then now we have chronic leukemia. What is with chronic leukemia? The onset is slow and gradual. Okay? What happens in chronic leukemia is this. This particular person is having, of course, they have the cancerous cell, but the thing is, there is a balance up. The proliferation of immature cells is is matching with the number of mature cells. So the balance, the difference is not, it's more like an average, it's more like 50-50. That's why there is the chronic leukemia. But immediately the proliferation of immature cells increases than normal. It goes up to it exceeds the normal cells, then that's going to be now acute. So this is what happens in chronic leukemia. The slow and gradual onset involves more mature but abnormal white blood cells, then excess production of abnormal white blood cells in blood, then disease progresses slowly over time. So now, we want now to look at the classification of leukemia based on the type of white blood cell that is being involved. So, based on the white blood cell that has been involved, it depends on where it's coming from. We have myeloid and we have lymphoid. So, it's either we have acute myeloid leukemia and we have chronic myeloid leukemia. So what is acute myeloid leukemia? Because we know that these myeloid, when we are looking at them, they are the progenitor cells that produces the white blood cells. You can see here all the white blood cells of this particular type, okay, except the lymphocyte, but most of them are being produced by the myeloid progenitor. So what happens is that in acute myeloid leukemia, this one represents about a quarter of all leukemias. The onset is abrupt, meaning very fast. Then it is common in older adults, 60-70%. Then there is uncontrolled proliferation of the myoblasts. Okay, the one I was showing you. You can see the myoblasts. Then there is sudden, like there is a surge in the sudden increment in the proliferation of myoblasts, leading to fake copies of this particular white blood cells. Okay. Then we also have acute lymphocytic leukemia. Remember the lymphoid organ that I was showing you, the lymphoid progenitor. We have lymphoid progenitor here, which produces the what? The lymphocyte. So what happens in this particular disease is that it is the most common in children and rapid progression that involves immature lymphocytes, which proliferates too long. So now, from those same acute, then we're just going to have chronic myeloid leukemia, which is slow onset, increased granulocyte in blood, common in adult, and then are often associated with the Philadelphia chromosome. And then 4, we are going to have chronic lymphatic leukemia. So it is about lymphatic leukemia or myeloid leukemia. But for us to get the 4 of them, we are going to have acute myeloid leukemia and chronic myeloid leukemia. Then we are going to have acute lymphoid leukemia and chronic myeloid leukemia, just like that. And you should be able to differentiate where they are common mostly. So now looking at what happens in the leukemia, like what really happens. So now when you look at basically we need to look at general signs and symptoms before we can go to medical investigation. So when you look at the general signs and symptoms of all leukemia in combination, we are going to have fatigue and weakness due to anemia. Remember I told you that because it proliferates over time and it's going to eat up the space that is supposed to be taken by the white blood cells. Then we have fever and recurrent infection because the white blood cells are not in their normal stance. They are not functioning to the capacity. Then we have breeding tendencies like breeding gums, epistaxis, because even platelets in this regard, they get to be affected. Then we have pallor that is going to come in because of anemia. Bone and joint pain is going to occur. Then we have weight loss and loss of appetite. The lymph node enlargement, this is just due to the infection that is there. So the lymphatic system is also trying to fight the kind of infection. Then we have hepatosplenomegaly, enlarged liver and the what? And the spleen. So we call it hepatosplenomegaly. So this hepatosplenomegaly is going to occur in the leukemias because blood is going to be trapped and clogged in those particular areas. Okay? Because this is a cancerous kind of blood. So on the medical investigations, we have full blood count. We want to look at the numbers of we want to look at less numbers of white blood cell. If the white blood cell number is elevated, then probably if the white in full blood count, if the number is elevated, then probably we have leukemia. Yes. So full blood count, on full blood count, we are going to have elevated number of white blood cells because they are infected, so they are going to be elevated. Then we have medical investigation. We can have lumbar puncture. Lumbar puncture is just to confirm whether this cancer has reached the brain and the spinal cord or not. So if it has reached there, in case of severe forms of leukemia, then you are going to find the cancerous cells as well. Then we have bone marrow biopsy. We want to just find out the development, like the state of the bone marrow. Has it been affected? Is it having some cancerous cells or not? Okay. Then medical management of leukemia, because it's a cancer. So just like how any other cancer is managed, except that here we can have what we call bone marrow transplant. Bone marrow transplant is what is going to differentiate the treatment of this particular cancer from other cancers. So we can have bone marrow transplant that is going to actually solve the problem of leukemia. But if we just want to put this particular patient on management, then we can use chemotherapy, radiation therapy, and then you manage symptoms, e.g. pain, giving analgesics, and then there's also targeted therapy where they use instruments to just kill the cancer cells. We are done with leukemia, and then now let's summarize with hemophilia. I've put hemophilia A because it's the most common one due to abnormalities with deficiency with factor 8. So what is hemophilia? Hemophilia is a breeding disorder. We have hemophilia A, B, C, and D. However, A is the most common one, and I've put A there. So this one is a breeding disorder. Why? Because it's going to come as a result of it's going to come as a result of malfunctioning of platelets. If the platelets are not functioning normally, okay, usually not necessarily directly with the platelets, but it's about affecting the cascade of events. Okay, so in hemophilia, what happens is that there's what we call coagulation cascade. When you cut yourself, blood start coming out. There's need to be a process for coagulation whereby platelets comes to aggregate at the site and everything, so that it can actually eventually be filled, so that they could be clot to be formed and everything, and that is done in a series of events. So what happens is, in intrinsic pathway, we have factor 12, which is called the Hegman factor. Okay, this Hegman factor, and then in extrinsic we have factor we have the thromboplastin. Okay, thromboplastin is factor 9. So what happens is that this factor 12 activates factor 11, then factor 11 activates factor 9, then factor 8 combines with factor 9 to form factor 10. So in the presence where factor 8 is having some kind of abnormality or deficiency, it's not enough, then this whole series is going to be affected, and we're not going to form the factor 1, which is a fibrinogen. Okay, because we need to form a fibrin. So now the problem with hemophilia, specifically type 1, that we are going to hemophilia A, is with factor 8, because factor 8 is important to combine with factor 9 so that they can form factor 10, so that this entire process can now continue. Now if we have deficiency in factor 8, then hemophilia A comes in. So hemophilia in general, not specifically A, B or C, but hemophilia in general is a hereditary bleeding disorder characterized by a deficiency or absence of specific clotting factors leading to prolonged bleeding. Okay, so in this case there is a genetic inheritance where the X chromosome linked get to be what we can say recessive. One thing about hemophilia is that it mainly affects males because it actually mostly affects the X chromosome. So family history of bleeding disorders or spontaneous gene mutation can lead to hemophilia. So under types of hemophilia we have 4, though here we're just going to talk about 3 of them. We have hemophilia A, deficiency of factor 8, which is very much important for it to combine with factor 9 so that they can form factor 10. We have hemophilia B, this is the most common. So we have hemophilia B, which is the deficiency of factor 9. Then we have hemophilia C, which is deficiency of factor 11. Okay. However, factor 8 is the most common one. So what happens is that if there's a deficiency of any clotting factor, we are going to impair the coagulation cascade. Inadequate formation of fibrin clot. So inadequate formation of this fibrin clot is going to lead to the wound not be able to heal faster. So this is going to lead to prolonged or spontaneous bleeding, especially into joints and muscles. So clinical presentation, these are going to be presented. There's going to be prolonged bleeding after a minor injury or surgery, hematolosis, bleeding into joints, pain, muscle, hematomas, easy bruising, nose bleeding, gum bleeding, blood in urine, intracranial hemorrhage, which is actually a life-threatening. Intracranial means blood leaks into the brain. So this is what happens in a hemophilia, specifically A, the type of A. Then the medical management of hemophilia includes just depressing targeted therapy, where they depress factor 8, okay? They depress factor 9, just like that, even giving some what we call antifibrinolytics, like tranexamic acid. So then we also involve on pain management, but you should by all means try to avoid aspirin and the NSAIDs, because they affect the prostaglandin production. Okay, so this is basically about the management of hemophilia, and here is where we are going to end. If you have reached up to this far, it means that you have really benefited from this tutorial. Just make sure that you subscribe so that you don't get to miss any notification about the future videos. Bye bye.